Hello everyone, this is a last-minute review of bacterial infections in children and high-yield clinical case scenarios. My objectives in this presentation is to discuss high-yield facts, focusing buzzwords and key points in clinical vignettes, differentiating bacterial diseases from each other that have some similarities. We'll start with vomiting and diarrhea. If you have a child presenting with watery diarrhea or blood and mucus in stool, history of eating poultry or contact with turtles with relatively short incubation period, less than 3 days, what is the most likely diagnosis? Non-typhoidal salmonella. Diarrhea with fever, generalized seizure, ill-looking tenesmus, what is the most likely diagnosis? Shigella. The keyword here, generalized seizure. Diarrhea, generalized seizure. Think about Shigella, diarrhea, and poultry or contact with turtles or reptile. Think about Salmonella. History of nausea, excessive vomiting, very short incubation period like 30 minutes or 1 hour or 3 hours. History of eating ham, poultry, cream-filled pastries, potato, and egg salads. What is the most likely cause? Staphylococcus aureus. It is because of preformed enterotoxins in certain food, for example potato and egg salads. Same presentation but after eating rice. What is the most likely cause? Preformed Bacillus cereus emetic toxins. Both cases, staph and Bacillus cereus, are because of preformed enterotoxins, and the treatment for both cases is supportive. No antibiotic is required. Diarrhea and abdominal pain mimic appendicitis after eating pork chitlins or tofu or associated with pharyngitis. What is the most likely cause? Yersinia enterocolitica. So if you have a child presenting with diarrhea after eating pork chitlins, think about Yersinia. Abdominal pain mimic appendicitis and pharyngitis, possibly from the affinity of Yersinia species to lymphoid tissue like mesenteric lymph node and lymph node in the pharynx. Bloody diarrhea after eating improperly cooked turkey or chicken. The most likely cause is Campylobacter species. Treatment in cases of Yersinia enterocolitica is supportive. Treatment in cases of Campylobacter is azithromycin to shorten the course of the illness and decrease excretion of organism. Diarrhea and hemolytic uremic syndrome, which is elevated BUN, creatinine, hemolytic anemia, and thrombocytopenia after eating beef hamburger, especially with rare or not well cooked roasted beef or unpasteurized juices. What is the most likely cause? Shiga toxins producing E. coli, especially serotype O157. Shigella dysentery serotype 1 can be associated also with hemolytic uremic syndrome. Stool culture at this point will confirm the diagnosis. What are the possible causes of diarrhea associated with reactive arthritis or Guillain-Barré syndrome? Campylobacter species, Shigella, or Yersinia enterocolitica. If you have a child received antibiotics 2 months ago, presenting now with diarrhea and abdominal pain, what is the most likely cause? Clostridium difficile. How to confirm the diagnosis? By detection of toxins A and B in stool. Treatment of choice is metronidazole. First time, metronidazole. First recurrence, metronidazole. Second recurrence, we cannot use metronidazole because of neurotoxicity. Oral vancomycin in the second recurrence, oral, not IV. In severe cases, you can also use oral vancomycin or even rectal enema in combination with IV metronidazole. Incubation period of C. diff varies from even the first day after taking antibiotic to 2.5 months. The average is 5 to 10 days. We have to keep that in mind. History of camping 2 weeks ago, foul smelling stool, anorexia, flatulence, and abdominal distension. What is the most likely cause? Giardiasis. This classic presentation after exposure to contaminated water or food makes the diagnosis of giardiasis is the most likely. How to confirm the diagnosis? By sending stool study using enzyme immunoassay or direct fluorescence antibody. This is the standard. The treatment of choice is metronidazole 5 to 10 days. Diarrhea, abdominal cramps, blood and mucus in stool, weight loss 4 weeks after traveling overseas or limited resource countries or immigrants. Amoebiasis. After this classic presentation, after exposure to contaminated water or food, traveling to limited resource countries or immigrants, think about amoebiasis. How to confirm the diagnosis? By stool study revealing trophocytes with ingested red blood cells ELISA to detect the entamoeba histolytica antigen. For patients with no symptoms, they have to be treated with paromomycin or iodoquinol if they have positive screening. For patients with symptoms, they have to be treated with metronidazole or tinidazole, followed by paromomycin or iodoquinol. Very important to know the association of amoebiasis with liver abscess or brain abscess. Exposure to recreational water, frequent non-bloody diarrhea. What is the most likely cause? Cryptosporidium species. The key word here, recreational water, water parks or swimming pools, then diarrhea. Very important to know that Cryptosporidium species also is a very important cause of diarrhea in immune-compromised patients. Confirm the diagnosis with a stool study using DFA, and the treatment is 3 days of nitazoxanide or Alenia. Long-term care facilities, schools, cruise ships, ingestion of ice, shellfish, ready-to-eat foods, abrupt onset of vomiting and diarrhea outbreak means a group of people. What is the most likely cause of this condition? Norovirus is the most common cause of viral gastroenteritis. Let's summarize what we have said before. If you have a child with diarrhea, eating poultry, or contact with turtles, reptiles, incubation period less than 3 days, the most likely cause is non-typhoidal salmonella. Diarrhea, seizures, high fever, ill-looking, Shigella. Bloody diarrhea, improperly cooked turkey or chicken, abdominal pain, mimic appendicitis, Campylobacter species. Abdominal pain, mimic appendicitis, pharyngitis after eating pork chitlins, Yersinia. Nausea and vomiting, very short incubation period after eating rice, Bacillus cereus. Nausea and vomiting, very short incubation period after eating potato salad, Staph aureus. Diarrhea after exposure to recreational water like water parks and swimming pools, Cryptosporidium. Immunodeficient, Cryptosporidium. Petting zoo, applesauce or cider, undercooked hamburger, unpasteurized milk, E. coli. Diarrhea after history of antibiotic intake as short as 1 day or as long as 2.5 months, C. difficile. Contaminated water or food, Giardia or Entamoeba histolytica after travel to resource-limited countries. Let's summarize specific treatment for certain types of bacterial diarrhea. Non-typhoidal salmonella. Treatment is supportive except if it is less than 3 months old or immunosuppressed. Treatment of cases of Shigella is supportive except if it's severely ill or immune suppressed. Campylobacter species, azithromycin to shorten the course of the illness and decrease excretion of organism. Yersinia, supportive care. Bacillus cereus, supportive. Staph aureus. These two organisms, Bacillus cereus and Staph aureus, they can cause severe vomiting shortly after intake of contaminated food with preformed toxins. And the treatment for both cases is supportive. Very important to know that Bacillus cereus can be associated also with diarrhea, and the diarrheal type is a different mechanism, but the treatment is still supportive. If you have an infant presenting with constipation, poor feeding after eating honey or home-processed food, what is the most likely cause? Clostridium botulinum. Also, patient may present with weak cry, hypotonia, loss of facial expression, loss of head control. The key point here to know that constipation may be the first initial manifestation. Diagnosis of botulism by detection of botulinum toxins in stool, enema fluid, gastric aspirate, or serum. Treatment is supportive, means ventilation, for example, nutrition, plus human-derived antitoxins should be given immediately. A newborn with presumed bacterial meningitis, what is the most likely cause? Group B streptococci, E. coli, and Listeria monocytogenes. Empiric treatment is ampicillin plus aminoglycoside or ampicillin plus cefotaxime. Infants and children with presumed bacterial meningitis. The most likely cause at this age group is Streptococcus pneumoniae and Neisseria meningitidis. The best empiric antibiotics to give at this point is vancomycin plus ceftriaxone or cefotaxime. A child accidentally used a toothbrush of his father just 3 days before his father was hospitalized in the ICU with a diagnosis of meningococcal meningitis. This child will need a chemoprophylaxis. The drug of choice for most of the children is rifampin. Regardless of immunization status, close contacts of all people with invasive meningococcal disease, they have to receive chemoprophylaxis. For example, household contact, especially children younger than 2 years of age, childcare or preschool contact at any time during 7 days before onset of illness, direct exposure to index patient secretions through kissing or through sharing toothbrushes or utensils 7 days before the onset of illness, mouth-to-mouth resuscitation, unprotected endotracheal intubation at any time 7 days before onset of illness, frequent slept in same dwelling as index patient during 7 days before onset of illness, passengers seated directly next to the index case during air flight lasting more than 8 hours. This is particularly high yield, very important to remember. 5-year-old with history of tick bite presenting with fever, petechial rash on palms and soles, severe headache, myalgia, low platelet, and hyponatremia. What is the most likely cause? Rocky Mountain spotted fever. Drug of choice in this case is doxycycline for all ages, even if it's less than 8 years of age. 5-year-old with history of tick bite presenting with fever, rash, myalgia, headache, pancytopenia, elevated liver enzymes, and hyponatremia. What is the most likely cause? Ehrlichiosis. Doxycycline is the drug of choice for all ages. It is difficult to differentiate between ehrlichiosis and Rocky Mountain spotted fever. Look for pancytopenia and elevated liver enzyme, just more suggestive of ehrlichiosis. But once ehrlichiosis or Rocky Mountain spotted fever suspected clinically, you have to start the treatment doxycycline immediately. Do not wait for any lab work results. Even if the child less than 8 years of age, you have to give doxycycline. This is particularly high yield. If you have a child played at a park in New England, target skin lesion more than 5 cm or erythema migrans, what is the best next step? Treat Lyme disease. Why? Because of geographic distribution. 90% of Lyme disease occurs in New England and eastern mid-Atlantic states, and the characteristics of the lesion more than 5 cm erythema migrans makes the diagnosis of Lyme disease. So you have to go ahead and treat without ordering serology test. Doxycycline if it's more than 8 years of age, amoxicillin if it's less than 8 years of age. If Lyme disease becomes disseminated or is associated with isolated facial pulse, the treatment is doxycycline or amoxicillin. Of course, if it's less than 8 will be amoxicillin, if it's more than 8 will be doxycycline for 14 days. Carditis, doxycycline or amoxicillin for 14 days. Arthritis, doxycycline or amoxicillin for 28 days. Meningitis, ceftriaxone for 14 days. In these cases, you will need to order the serology test to confirm the diagnosis. A child visited Oklahoma with family. They hunted and skinned rabbits, and the child presented with large lymph node in the groin and fever. What is the most likely cause? Tularemia, caused by Francisella tularensis. Drug of choice is streptomycin. Buzzwords to look for in the vignette: skinning rabbits and lymphadenopathy. Axillary lymphadenopathy and kittens or cats at home. What is the most likely diagnosis? Cat scratch disease caused by Bartonella henselae, even if no history of scratch. If the diagnosis is unclear or severe systemic manifestations, you can confirm the diagnosis with serology testing. By most of the experts, the treatment of cat scratch disease is supportive. No antibiotic is required. If you have a painful suburative lymph node, you will do needle aspiration. Needle aspiration is the correct procedure, but no incision and drainage because these can cause fistula. A bite of a cat, dog, or other animals 12 hours later presents with swelling, tenderness, erythema, serous or sanguinopurulent discharge at the site. What is the most likely cause? Pastorella species, the key word here, short incubation period after animal bite. Drug of choice for Pastorella species is penicillin, but practically after animal bite, the drug of choice is amoxicillin clavulanic acid to cover for staph as well. Dog, cat, or human bite 5 days later presents with swelling, erythema, tenderness, or tissue cellulitis at the site. What is the most likely cause? Staphylococcus aureus. The key word here that the incubation period longer than Pastorella species. The best next step after animal bites is wound irrigation. Drug of choice for animal bites, amoxicillin clavulanic acid, or what is well known as augmentin. If the patient is hospitalized, you are able to give IV ampicillin, sulbactam. If the patient is allergic to penicillin, you can give clindamycin and trimethoprim sulfamethoxazole. Fox, raccoon, bats, skunks, or other carnivores post-exposure prophylaxis. These animals are considered high risk for rabies, and the best next step is immunization and rabies immunoglobulin, even if they mention in the vignette that the bat found dead in bedroom. If you have a bite from a domestic dog and the dog is healthy and available 10 days of observation, what is the best next step? Prophylaxis only if animal develops signs of rabies. Dog is rabid or suspected of being rabid. Immediate immunization and rapid immunoglobulin. Tetanus prophylaxis in routine wound management will start with clean wounds. If you have a clean or minor wounds and is less than 3 immunization or unknown, what to give next? Vaccine only, no tetanus immunoglobulin. If you have clean or minor wound more than or equal 3 immunization and more than or equal 10 years, vaccine, no immunoglobulin. Clean or minor wounds more than or equal 3 immunization less than 10 years, no vaccine, no immunoglobulin. Dirty and major wounds, if you have dirty or major wounds and less than 3 immunization or unknown, vaccine and tetanus immunoglobulin. If you have dirty or major wounds more than or equal 3 immunization more than or equal 5 years, vaccine, no immunoglobulin. Dirty or major wounds more than or equal 3 immunization less than 5 years, no vaccine, no tetanus immunoglobulin. A 5-year-old presenting with fever, headache, pharyngeal erythema, palatal petechiae, abdominal pain, and nausea. The most likely diagnosis is streptococcal pharyngitis. If you have a child presenting with the classic presentation of viral infection, for example, cough, runny nose, hoarseness of voice, conjunctivitis, diarrhea, there is no need to perform rapid strep or throat culture, just reassurance and supportive care. If you suspect bacterial infection, perform rapid strep. If rapid strep is negative, do throat culture. If throat culture is positive, start antibiotic. Streptococcal pharyngitis plus rash, and the rash is diffuse erythematous, blanching, fine papular rash that resembles sandpaper on palpation. What is the most likely diagnosis? Scarlet fever. Scarlet fever can be associated with discoloration of the skin and strawberry tongue. Antibiotic of choice for streptococcal infection in general is penicillin VK or oral penicillin. Amoxicillin can be given once daily for 10 days. Benzathine penicillin injection one time. In children, they have trouble taking the oral medicine. For penicillin allergic patients, you can give cephalexin, cefdinir, clindamycin, or azithromycin. Adolescent with unilateral neck and ear pain, dysphagia, odynophagia, hot potato voice, trismus, pooling of saliva, and a unilaterally enlarged erythematous tonsil. What is the most likely diagnosis? Peritonsillar abscess. Streptococcus pyogenes is an important cause of peritonsillar abscess, and penicillin remains the drug of choice. If you have a child presenting with fever, pharyngeal exudate, lymphadenopathy, 4 days later developed rash and the rash is pruritic. On physical exam absent palatal petechiae and strawberry tongue, you perform rapid strep and came back negative. What is the most likely diagnosis? You decide to perform a throat culture on rabbit or human blood agar, and it grows gram-positive, club-shaped bacillus, catalase negative hemolytic bacteria. What is the name of this bacteria? Arcanobacterium hemolyticum. The keywords for this bacteria: pharyngeal exudate. 1 to 4 days later, the patient may develop rash, and the rash is pruritic. Unlike streptococcal infection, this bacteria is not associated with palatal petechiae or strawberry tongue. Plus, rapid strep test will be negative and is difficult to detect on ordinary sheep blood agar and require a special media to grow a larger colony in a short time. The drug of choice is erythromycin or azithromycin. Unimmunized child presenting with throat pain and fever appears quite toxic with large tonsils, 2 plus bilaterally, with a thick gray exudate, bilateral cervical lymphadenopathy, intercostal retractions with occasional rales, distant first and second heart sound with S3 gallop. What is the most likely cause? Corynebacterium diphtheriae. Immediately give antitoxins and antibiotic, for example erythromycin or penicillin IV for 14 days. Fever, chills, erythema of the skin with red streaks, rapidly growing, sharply defined, elevated borders, and tender to palpation. What is the most likely diagnosis? Erysipelas or streptococcal cellulitis. The key word for this bacteria: sharply defined and tender erythema of the skin. History of minor or unrecognized trauma to an extremity, for example foot or arm, presents as pain out of proportion to examination findings. Then within hours rapidly progressive with significant inflammation, blisters and bully. What is the most likely diagnosis? Necrotizing fasciitis. The key word for necrotizing fasciitis is pain out of proportion to examination findings. This is considered a surgical and medical emergency and has to be managed immediately. Fever, generalized erythematous rash, rapid onset, hypotension, multi-organ failure, DIC, soft tissue infection. Culture is positive for gram-positive cocci in chains. What is the most likely diagnosis? Streptococcal toxic shock syndrome. Critical points we need to remember about toxic shock syndrome. Blood culture is usually negative in cases of staph, is positive in case of streptococcus pyogenes. Common triggers in case of staph: nasal packing, tampon, deep abscesses, osteomyelitis. In case of strep, necrotizing fasciitis, myositis, or cellulitis. Severe pain is common in case of streptococcus pyogenes. Hypotension, low platelets, and renal failure are common in both. Mortality is high in cases of streptococcus pyogenes. Antibiotics of choice: clindamycin, nafcillin, oxacillin, cefazolin, or vancomycin if penicillin allergies or MRSA. Clindamycin plus or minus penicillin in cases of streptococcus pyogenes. Neonate with central line presenting with fever, multiple positive blood cultures for staphylococcal coagulase negative bacteria while on appropriate antibiotic therapy. What is the next step? Remove the catheter. History of intravenous drug abuse. Presents with fever, dyspnea, cough, chest pain, tender subcutaneous nodules in the distal nail pads, non-tender hemorrhagic macular lesions in both palms and soles, positive blood culture for Staph aureus. What is the most likely diagnosis? Bacterial endocarditis. Empiric antibiotic of choice is vancomycin plus gentamicin. While taking IV vancomycin, suddenly developed rash, itchiness, flushing, and tachycardia. What is the most likely diagnosis? Red man syndrome. The best next step is to discontinue IV vancomycin, give IV diphenhydramine. If no more rash or itchiness, resume the IV vancomycin but at a slower rate. History of recurrent urinary tract infection, recurrent catheterization. Urine gram stain is positive for gram-positive cocci in pairs and chains or enterococcus. What is the best treatment for this case? Ampicillin. Enterococcus is sensitive to ampicillin. Keywords for enterococcus in cases of urinary tract infection are recurrent catheterization, gram-positive bacteria. So enterococcus is gram-positive while E. coli is gram-negative and is resistant to ampicillin and is sensitive to cephalosporins. Limping after stepping on a nail with a sneaker. Pain and swelling in the ear helix after ear piercing. What is the most likely cause? Pseudomonas aeruginosa. Be familiar with the treatment of Pseudomonas aeruginosa. As outpatient to oral, you can give ciprofloxacin. IV, you have multiple choices: ceftazidime 3rd generation, cephalosporin, or cefepime 4th generation, ticaracillin, clavulanic acid, piperacillin, tazobactam IV, or tobramycin IV. Fever of unknown origin. Lives in a farm. What is the most likely cause? Brucella. Blood culture is the best test for brucella and doxycycline is the drug of choice. Fever for 7 days, hepatosplenomegaly, history of travel to a resource-limited countries. What is the most likely cause? Salmonella typhi or enteric fever. The best test is blood culture and the best empiric therapy is ceftriaxone IV until the culture and sensitivity is available. A 3-day-old child developed osteomyelitis. Culture is negative and not responding to vancomycin. What is the most likely cause? Kingella kingi. Why Kingella kingi? Because the child is having osteomyelitis, culture is negative and not responding to vancomycin. Staph aureus is the most common cause of osteomyelitis and is still sensitive to vancomycin in most of the cases. So in this case, we have to think about other bacteria. Usually requires a special media to grow with CO2 enhanced culture. The best treatment for Kingella kingi is ceftriaxone or 3rd generation cephalosporin. 2-year-old child who is unimmunized presents with high fever, rapid onset of throat pain, hot potato voice, sitting up on hands with tongue out and the head is forward, drooling and crying. What is the most likely cause? This is a classic presentation of epiglottitis. Haemophilus influenza used to be the most common cause before immunization. The keyword in this vignette is unimmunized. So Haemophilus influenza is the most common cause in this case, which is a pleomorphic gram-negative coccobacillus. Immediately manage airway, for example, endotracheal intubation, oxygen, and provide appropriate antibiotic, for example, ceftriaxone or amoxicillin clavulanic acid. 2-year-old boy recently diagnosed with invasive Haemophilus influenza type B meningitis. His contact brother is 3 years and incompletely immunized. What to do next? Rifampin prophylaxis to all households. Household contacts to a patient with Haemophilus influenza. We have to give rifampin to all household members if you have less than 12 months who has not received second or third dose of Haemophilus influenza vaccine, or less than 4 years of age who is unimmunized or incompletely immunized. You have to give rifampin to all household members if you have immune compromised child, regardless Hib immunization status or age. In case of a child care or preschool, rifampin prophylaxis for all attendees if 2 or more cases of invasive Haemophilus influenza disease have occurred within 60 days, or unimmunized or incompletely immunized children attend the daycare facility or preschool. 4 months old with persistent cough for 3 weeks, associated with vomiting, gagging, gasping, bradycardia, and apnea. What is the most likely cause? Bordetella pertussis. PCR is the test of choice. Azithromycin is the treatment of choice. Vaccination DTaP if it's less than 7 years, Tdap if it's more than 7 years, and azithromycin for all contacts. Mother or household contact has positive tuberculosis skin test or IgRA or quantiferon result and normal chest X-ray findings. What is the best next step? If the mother or household contact is asymptomatic, no separation is required. Do not delay hospital discharge. Allow breastfeeding. Other household members should have a skin test or IgRA or quantiferon and further evaluation. Mother or household contact has clinical signs and symptoms or abnormal findings in chest X-ray consistent with tuberculosis disease. What to do next? Test the infant for congenital tuberculosis. Test the mother for HIV infection. Infant should be separated until the mother or household receive an appropriate anti-tuberculosis therapy. Breastfeeding 2 weeks or more after successful therapy has started. If congenital tuberculosis is excluded, isoniazid is given until the infant is 3 or 4 months of age. And this is the time when a skin test for tuberculosis should be performed. Mother or household contact has a positive skin test or IgRA or quantiferon and abnormal findings on chest X-ray, but no evidence of tuberculosis disease. What to do next? No separation from the mother or household contact. The mother and her infant should receive follow-up care, and the mother should be treated for latent tuberculosis. Other household members should receive a skin test, tuberculosis skin test, or blood test, IgRA or quantiferon, and further evaluation. 6 years old exposed to a household member with active tuberculosis. What to do next? Do tuberculosis skin test or blood test, IgRA or quantiferon test, chest X-ray, and complete physical examination. If TB skin test is negative or blood test is negative, start isoniazid. Repeat the test in 8 to 10 weeks. Discontinue isoniazid if TB skin test or blood test is negative. If TB skin test or TB blood test is positive, the regimen for latent tuberculosis should be completed after an evaluation for tuberculosis disease, which is a 9-month course of isoniazid. Conditions and antibiotic of choice: acute otitis media, high dose of amoxicillin 80 to 90 mg per kilo per day for 10 days. Pneumonia, ampicillin, amoxicillin, second generation cephalosporin, and can be given oral as outpatient. For inpatient cases, you can use third generation cephalosporins. For school-aged children, azithromycin. Sepsis in newborn, ampicillin, gentamicin. Suspected meningitis in less than 3 months old, ampicillin and cefotaxime or ceftriaxone. Suspected meningitis in infants and children, vancomycin and ceftriaxone or cefotaxime. Staph aureus, MSSA, cephalexin or cefazolin, MRSA or MRSA, trimethoprim sulfamethoxazole, clindamycin or vancomycin. Antibiotics we can use for UTI caused by gram-negative E. coli, cephalexin, cefazolin, trimethoprim sulfamethoxazole, third-generation cephalosporins, gentamicin, ampicillin, and amoxicillin. The resistance is very high. Streptococcal infection, oral penicillin. Mycoplasma pertussis, chlamydia, macrolides, for example, azithromycin or erythromycin. Rocky Mountain spotted fever or ehrlichiosis, doxycycline for all ages. Pneumocystis jirovecii pneumonia or pneumocystis carinii, trimethoprim sulfamethoxazole for prophylaxis, trimethoprim sulfamethoxazole plus another agent for treatment.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.